struggled immensely. And I have far more knowledge than the typical patient and far more privilege than the typical patient. And in spite of that, I got the wrong diagnosis initially.
Hello, everyone. Welcome to another episode of HuMed, Human Medicine. I'm your host, Dr. David Spiro. This is a show where we unveil what's really happening in healthcare with real doctors, real stories, and really an opportunity to get to meet someone in a different way who's involved in healthcare. And for those of you that are or aren't, to have a deeper understanding with the crazy world that we live in. I'm incredibly delighted and honored to have Dr. Josh Daly. Welcome to the show. Josh hails from Little Rock. He went to the University of Arkansas for college and then UAMS for med school, and then did something smart, which I think I've done too much of, is he moved away from where he went to medical school and went to one of the top 5 or 10 places for pediatric residency in the country, which is the University of Cincinnati, and then stayed on there for their pediatric cardiology fellowship program. And then we were fortunate here in Little Rock to recruit him back to faculty, where he was an assistant professor and then an associate professor. And during his time here, he has developed an interest in education, near and dear to my heart. So he's the director of the fellowship program. So he's the guy you want to know if you finish your peds residency program and you want to become a cardiologist and study here in Little Rock. He's the guy. And then he's also developed a very interesting expertise in finance. He's the director of a 4th-year medical student course in finance, which is one of the only ones in the country that deals with that. And then on top of that, he is a regular poster on Substack and has just written a book around the intersection of medicine and faith. And Josh, welcome to the show.
Dave, thanks for having me. It's a pleasure to be here.
Yeah, at HuMed, human medicine is really about this journey that I'm on and we're on, whoever's subscribing, please hit subscribe. But it's really a journey around getting to know people in an intimate and more visceral way. And I really have known you a little bit through some of our interactions in the ED when you come down and we talk about patients and through faculty stuff. But I really would love to get to know you a little bit more. And my understanding is you have a story about your own journey as a patient, and I would love to hear more about it.
Yeah, I'm happy to share. There's a number of directions we could go with this, but I thought it would be most helpful to tell a little bit about my story as a patient and how my perspective has changed, both as a patient and as a physician, and share a little bit out with some of your listeners today. I had no health issues earlier on in my life. I got married, had 2 kids. I now have 4, and had been back here in Arkansas for, at the time, about 7 years ago, or about 7 years. So it was just about 4 years ago. And we just had my 4th child, Ellie, and she was about 5 months old at the time. And I had gained some weight. I felt tired all the time. And I attributed both of those to both being in my late 30s, having a 4th child, being up at night, taking call, all the typical things that we would explain that away. I was not very worried. My wife was, as is often the case. I eventually got around to seeing my PCP, and we sent some screening labs, and things overall looked okay, but I was a little bit anemic, which wasn't entirely clear what the cause of that was. And then my testosterone was extremely low. And my PCP just attributed to, oh, you're a man, in your late 30s, this happens. Let's just start you on testosterone. So being a physician myself, I recognize I did a little bit of review of the literature and realized we should probably pursue some additional screening laboratory values. And we ended up getting some additional labs, and they indicated that the cause of my low testosterone was something in my brain. And in particular, for those that are physicians, something called an LH and FSH were low. And this was in the latter stages of COVID. It was very difficult to get an MRI. It was a long wait to get that. And simultaneously, I started having some headaches, and each could be individually explained away. One was in the context of a viral illness. Another was actually after a COVID shot. And then one night I had a headache that kept me up most of the night, and I was vomiting. And I'm a doctor. I know what the red flags are for a brain tumor or something else going on in my brain. So I showed up in ER the next morning, And I had, as is typical for many physicians, I'd called ahead and talked to a friend who was in the ER, and they got me in quickly and got the resident in. I'd already talked to some neurosurgery friends of mine, had the exact instructions for the MRI that I needed to get and exactly how it was supposed to be done. And interestingly, the resident was happy to oblige and get the ball rolling. The attending was not. She was a little off put that I would dictate my own care. She actually informed me that it was inappropriate for me to get an MRI in the ED, and that needed to be arranged as an outpatient. And I pushed back, and after some back and forth, she eventually agreed. Got an MRI, and it showed what at the time was about a 2.5 by 2.5 centimeter mass right in the middle of my brain, right in what's called your third ventricle. So nestled in the very center of my brain, around a number of structures that are very important from hormone regulation to consciousness to emotion, a variety of other issues, my vision. And I vividly remember in walks the neurosurgery intern an hour or two later, very nervous. He tries to explain to me what is going on. At this point, I'd had read more about it than he had. And the long story short, they ended up admitting me. And the radiologist got it wrong. The radiologist thought it was a germinoma and was fairly confident of that. The team comes in, the neurosurgeon came in the next day, was explaining to me what a germinoma was and that we should proceed to radiation. Meanwhile, I'm sure I broke some rules along the way, but I was doing whatever I could to make sure I got the care I needed. So I got a hold of my own MRI and sent it out to a number of friends that are neuroradiologists. And I
And a
was
germinoma, just for the audience to know, you know more about it than me, but it can be a fairly aggressive tumor with a poor prognosis. Is that correct?
It can be, but what's really important here is the way you treat it is different than what I ended up having, which I'll kind of get to in a moment.
Okay.
So they wanted to proceed straight to radiation, and they thought that was the way you treat this. Meanwhile, I'd sent out my scan to a bunch of other people, and one of our own pediatric neuroradiologists, who I trust greatly, looked at it and said, "Stop them. They got this wrong." And he was convinced it was a craniopharyngioma, which is a different kind of brain tumor that is also highly problematic, but problematic in a different way than a germinoma, and typically is not treated with radiation as the first step. So we got a whole bunch of tests. I eventually was sent home from the hospital because it wasn't emergent and had a follow up that next Monday with the neurosurgeon. And I had read in that interim, I think I read every single PubMed article published on craniopharyngiomas, became very up to date. And they'd kind of come across some more recent testing that looked at the genetics and whether they may respond to what's called targeted therapy. It's kind of like an oral chemotherapy. It was very in the early stages. And there have been just a little bit described. So I met with the neurosurgeon, brought that up about those mutations, and his answer to me was, "Oh, that's not really a thing. I don't know what you're talking about." Not, "I don't know. Let me check into this." And I'm a doctor. Like, I know how this works. Just because you think it's not a thing does not mean it's not a thing. So I got a lot of second opinions, a lot of other places, and ended up identifying the oncologist who had described this mutation, called the BRAF mutation. And she was at Harvard, and reached out to her, and we talked about whether I should pursue this treatment that was pretty investigational at the time. And the long story short, we decided to proceed with surgery. So I found another neurosurgeon who had done more of these than about anyone in the US and had some really good outcomes. Although interestingly, in the field of neurosurgery, there's no such thing as public reported outcomes. So in my field of congenital heart surgery, I can look up any surgeon, any center, and I can see what their outcomes are. So every surgeon thinks they're great. You're not going to come across one that says, "Yeah, I'm below average." So you really have to look at the data to assess how many they've done, what their outcomes are. All that to say, that doesn't exist in the field of neurosurgery, which is surprising, but it doesn't.
Why does it not exist in the field of neurosurgery?
That is complicated. I actually wrote a whole paper about it after my experience. But there are a bunch of sources and there's a lot of incentives to not doing that. And there's a lot of downside to public reported data that we actually deal with in our own field. For instance, you end up cherry picking patients. Like if you're
Mhm,
judged on mortality, you're less likely to actually operate in a high risk patient. That's one
mhm.
downside. So there are pros and cons, but it doesn't exist. I think it should, but in a very thoughtful way. But I was left as a physician to kind of, through talking through just a lot of my colleagues that have worked with this neurosurgeon and others, this is who was recommended. So I ended up right at 4 years ago now, had a complete resection, pretty high risk. I'd had other neurosurgeons tell me it was inoperable, that they would not operate and didn't think they could get all of it without causing some really big issues. And the bottom line is I had a really good result. They got the entirety of the tumor. I had a little bit of diabetes insipidus, which is one of the known problems. That's where you basically, a hormone that's made in that part of the brain helps your kidneys know whether to concentrate urine or just make urine. And I had a little bit of that postoperatively, but that resolved. my third nerve, which is a nerve that controls my right eye, got dinged in the process. And so my eyelid drooped and my eye was fixed down and out. And that lasted about 4 to 5 months. That eventually recovered. And I ended up having to take some testosterone and then thyroid medication. Those functions never recovered. But other than that, I was basically back to normal, which was just a gift. I recognize all the ways things could have gone. So that was about 4 years ago. And for the most part, I returned to life as usual. I continued to work full time, fully engaged parent at home. And that kind of brings it up to last summer. So as the summer was progressing, I was noticing I was peeing a little more frequently than I had in the past. And I was even more attuned to that because I knew what to look for with regard to a recurrence. But I'd had an MRI at that point 6 months before it was clean. And showed no tumor. So I thought, there's no way a tumor went from nothing to so big that it's causing problems in 6 months, especially the kind of tumor I had. It's not
Mhm.
supposed to behave like
Mhm.
that. So I ended up, we were leaving for vacation to go to Northern Michigan, which is where my sister lives. And I called my endocrinologist, said, I'll just come and get some labs right before you go. Came in and got some labs and we checked multiple things. And the bottom line is everything came back within normal limits. In retrospect, they're at the very low end of the normal limits. I was tipping into having a number of issues hormonally that I now recognize. At the time, I didn't. And I didn't want that to be true. I didn't want to have a problem. So I was naturally drawn to interpret data that favored me being fine. So went up to Northern Michigan. Meanwhile, my vision was starting to deteriorate a little bit. I was having trouble seeing at a distance. And I thought I probably need glasses. And while we were in Michigan, it seemed to be getting worse. And then we were driving back. It was an 18-hour drive with all my kids in the car in the back. And I'm struggling to see the car in front of me. And I still vividly remember this. My wife's sitting next to me and I started assessing my visual fields. And I realized my peripheral vision, the vision on the side, was just rapidly deteriorating, which for those that aren't medical, that's a very clear sign that that something is not wrong with the eyes, but the very center of the brain, which is right where my tumor had been. And so we pulled over. My wife was willing to drive the rest of the way home. And I pulled all the personal connections that I could and got in first for formal vision testing the very next morning, which confirmed what I suspected, that I had this very clear visual field defect and of having some difficulty getting an MRI scheduled. So one of my friends, who's a pediatric neuroradiologist, said, come to the children's hospital, get here at 5:30 a.m. We'll just scan you before the day begins the next day. I show up there, get scanned, go to the hospital chapel where I'm waiting, which is the same place as a doctor. I talked to a number of families dealing with difficult things. And then I get the phone call. And it's my good friend who's the neuroradiologist, the same one that figured out the first time. And he said his back was bigger than it was last time. And it was compressing, in this case, my optic chiasm, which is the part of the brain that's involved in vision. And my vision was deteriorating rapidly. And so I had this very narrow period of time to make a decision about what to do. So I call my neurosurgeon, who I am so appreciative for. And in typical fashion, he wants to, he's like, I got it once, I can get it again. And yes, he is very skilled and had a good outcome the first time. But when I looked at the literature, redos in that area, the outcomes are not good. When it comes back the first time, and I so badly wanted to believe that I'd be the exception to that, but I couldn't dismiss that. I mean, the odds were I'd have a bad outcome with that I'd have a lot of issues related to going back in that area. And in spite of a good resection the first time it came back. So I reached out to the same oncologist who had described that mutation, who's at Harvard. And I was so grateful. And I know this has only happened to me as I'm a doctor. I recognize that. She called me right away from Tokyo. She stepped out of a meeting in Tokyo and called me on her cell phone. And we talked about the next steps. She brought me up to date on the very latest research in that area. And we decided to start this targeted therapy. She couldn't prescribe it for me for a variety of reasons right then. So I had to find a doctor to prescribe it for me. And there wasn't a single neuro-oncologist in the entire state of Arkansas. So there was no one even locally that could handle this. So I called every friend I knew, everyone with a connection, and found an oncologist locally who used this exact same treatment regimen regularly for melanomas. And so is very familiar with the meds and the side effects and how to do that. Wasn't a neuro-oncologist. And I'm so grateful for him. He said, we'll figure this out together. Come in right away. So I came in the night before. He had stayed up and spent like 3 hours reading everything he could about craniopharyngiomas. And so he was able to get me samples right away. They're pretty expensive. It's hard to jump through. That very next day, I started on it. Had to get a ton of screening stuff. You do on the baseline and then to watch for side effects and was so grateful for him. Within 2 weeks, my vision started recovering and it was
Wow.
noticeable. And I almost didn't want to believe it at first that I could see better. And I got formal testing in 2 weeks later and it was like night and day, the difference. And it, for which I did not anticipate it would shrink that fast. And right after I got my vision tested and it was clearly getting better, I get the denial from the insurance that no, it's too expensive. We're not paying for this. The research
Because it's
doesn't show it.
experimental.
Yeah, because my tumor is so stinking rare that there's not enough research out there. And so it's not indicated for that. It's indicated for other things, and it's expensive. And so I did everything I possibly could, including make a number of threats. And I figured out who in our own institution was making those decisions and made it very clear that it would be highly problematic for them if their own physician ended up losing his vision because they wouldn't approve this medication. It was clearly working. And I recognized the typical patient could not have done what I did. And it was primarily a function of the privilege I have as a doctor. I get that, but it got
So you got
approved.
it approved. Wow.
Yeah,
Wow.
yeah, yeah. I got it approved, and my doctor, who was not a neuro-oncologist, went to bat and did everything he possibly could. Wrote letters, made phone calls, waited on hold, made it very clear this would go poorly for them. That they denied this for a physician at their own institution that self-insures. Our institution pays for our insurance, so it's people at our institution making that decision. But it got approved and stayed on it. My next MRI was at a month in, and it had already shrunk by 90% in volume in a
Wow.
period of a month. I mean, it was just melting away. Just
Wow.
extraordinary, which when you look at the literature and the few cases that are out there, there's not a lot published. It had had as robust a response as has been described. And so I've stayed on it since then, and it's continued to slowly melt away. My last MRI was about 2 weeks ago, and it's about the size of a sesame seed now. So it was originally about a little bit bigger than a golf ball last summer, and it's now on the order of 2 millimeters by 2 millimeters. It's tiny. It has just melted away. Now I've had some difficulty along the way. I'm on 2 different medications, and one in particular started to cause my muscles to break down. So for those that are physicians, my CK level, which is a marker kind of muscle inflammation, started to climb. And I had what's called rhabdomyolysis, when your muscles kind of start to break down, and there's risk of that damaging your kidneys. And we were following that closely. So we were able to have a period of a few weeks off. My numbers recovered. So it was clear what the offending agent was, that it was that one medication. And then we restarted a lower dose. And so far, I've tolerated it well. But I'm also acutely aware that just because I've tolerated it so well up until now does not mean I will continue to. There are a number of people that have issues. There's lots of problems that these medications can cause. I mean, they're toxic to your body. And I've tolerated it about as well as I could hope, but that doesn't mean I always will. Additionally, there is no long-term data on using this treatment regimen for this tumor. I just saw my oncologist at Harvard. I kind of see her and then my local oncologist, and I've kind of whole team. And she had one patient that it was now 5 years out with treating entirely with this. It hasn't had a recurrence yet. So that's the longest long-term follow-up data that's available.
Well, because the agents have only been around for
Yeah,
4 or
just
5
haven't been around.
years. I mean,
Yeah.
and this is considered a biologic? Is it considered, can you be a little bit more specific
Sure.
how the agent works?
Sure, there's 2 medicines that work synergistically. One's what's called a BRAF inhibitor. So the specific receptor that you have in your entire body that does normal functions, and this blocks the function of that protein. And in this kind of tumor, it's highly reliant on that. And then I'm also on what's called a MEK inhibitor, which is another pathway that this blocks. And basically, all the rest of your cells have other ways to get to function, even if those are blocked for the most part. Whereas this tumor is highly reliant on that. So it's a tumor that's used in a variety of different kinds of cancer, like melanoma that's metastasized, for instance, and some other types with really good results. But it's been a real game changer for craniopharyngiomas that have this mutation, which the vast majority of adult type craniopharyngiomas end up having this. So we're kind of on the cusp of, I think, the treatment approach fundamentally shifting in this field. And I'm very aware, had this happened to me 10 years earlier, this would not have been available at all. And even 4 years ago, all I had was a few patients, a few case reports that were all like recurrences that were unoperable. They said, well, let's throw this at it and just try. And it seemed to work. So I am extremely grateful that for the advancements in medicine, and in particular for my doctor, Dr. Brastianos in Harvard, we often think about the research that people do and from just a curiosity perspective and excitement perspective. But had she not pushed the envelope and said, I'm going to figure this out, I don't know where I'd be today. I'm so
Mm,
grateful that she was willing to do it, not only to be a kind and caring doctor, but to really strive for excellence. And that has shifted some of my my how I think about doctors in her role. And I recognize I've been the benefactor of the work that she did, the risks that she took, the way she's willing to push the envelope. And I would encourage anyone listening today that does research that you don't know what patients like me might be out there and they benefit
mm.
from the work that you're doing. And I don't do bench research myself. I do a lot of other stuff academically, but I am so grateful for those that are willing to engage in the space.
So, Josh, just for the audience, can you give us a sense of what the monthly or annual cost would have been for this therapy if it weren't covered by insurance?
The cash price, if there's no discount, which I was trying to, one of the things I was doing is trying to pay cash for it and to negotiate a discount with the actual manufacturer. But the cash price is about $20,000 a month if you don't get a discount. And maybe I could have gotten a discount if my insurance would have denied it. So I was trying to figure out how I was going to cover that. Also, with the real risk, I was going to be disabled, especially with my vision and thinking about my family and 4 young kids and having an income stream moving forward. And I mean, you can do the math. If I had to pay 20,000 a month and I'm on it for 2 years, that's a lot of money. And it's hard to cover that.
And you could be on it for the foreseeable future. And if that 5 years turns into 10 or 15 from that other patient, that may forebode an incredibly positive prognosis for you. And
Mhm.
it could be the cost of that therapy could be in the millions of dollars if you cost prohibitive, even for us physicians who have financial resources.
Yeah. Now the hope is that I'll come off it probably next year thereabouts
Mhm.
based on the rate of shrinkage of my tumor, but that's uncertain. I mean, we're kind of figuring it out as we go. But yeah, this is why people get health insurance for these
Mhm.
very unlikely events that are extremely expensive that you can't just budget for that, even as a physician like you or me. So
So I have a number of questions for you. So, by the way, first of all, thank you for being vulnerable and sharing the story. It has affected my heart, and it's very beautiful that you're willing to share the story. And I think there's a lot to learn that I've already learned, and I have some questions to learn even more. We as physicians are privileged to learn about the human body, and you and I are pediatricians at our core. And you had initially talked about at the beginning of the story that there was a delay and maybe you seeking care. And I'm curious, looking back at the first time that you were diagnosed, what is it about being a physician that is almost counterintuitive or almost harmful in some ways that we tend to be more deniers? What is that about us that, because we know a lot, and like you knew or around the second diagnosis that maybe I have a hemianopsia or I have some sort of and you sort of went through it in a very methodic way, but not the first.
yeah. I I think there are probably multiple layers to that. Part of it, if I'm honest, is just being male. I think we
Mm,
tend to not to just dismiss things or think we're fine.
mhm,
And so some of it's that. Some of it is the fact I'm a specialist and I get patients referred to me all the time, people worried about they're fine. And so that tends to be my default. And part of it in this case is that a lot of the symptoms individually I could explain away by whether it be a viral illness or the COVID shot or something. When you put a look at them in totality, it tells a story. But I wasn't viewing it that way. It's with each one that it came along sequentially, I could explain it away. And our minds are powerful. There's something called confirmation bias and motivated reasoning, where it's really interesting. You would think that the more intelligent we become and the more we know, the more rational and the more protective that we should be from cognitive bias, from these errors. But in reality, that is not necessarily the case when you look at the literature. Is you become more intelligent and have more data, you become better at arguing for what you want to be true. So what I was able to do in those situations is I might have a headache, even a headache that I was on the floor feeling terrible, that the average non-physician might say, this is bad, we have to go in. But I had enough information that I could figure out a very rational way of explaining it that sounded reasonable and that happened to align with what I wanted to be true, which is I didn't want it to be a brain tumor, but I also didn't want it to deal with the ER in the middle of COVID and all that
mhm.
hassle and all the dealing with everything that goes along with that. So we are so motivated to draw conclusions that align with what we want to be true. And as physicians, we are better at constructing arguments that support that. And then as specialists in particular, I think we may be even more prone to that as well. So that's my initial 2 cents on why we tend in that direction. And I think that explains a lot of what I ended up.
When you went to the emergency department the first time as an ER physician, I'm also curious. You said there was some conflict with the attending because the attending perhaps wanted to get a CT scan and not an MRI, or thinking this is just something that can be done on an outpatient basis. And you had a plan coming in based upon your knowledge and expertise. Could you get into that a little bit? I'm curious how you ended up getting to an MRI and convincing the ED attending, and what you learn, or what we can all learn around that as providers when we take care of other providers.
Yeah. Well, one, there were probably multiple elements of that. And I don't know the ER doc story. What I do know is in the middle of COVID, she may have been burnt out at the time, been overworked. It may have been the end of the shift. And she may have been dealing with a lot of people making unreasonable, necessary demands. And mine was one additive demand on top of all of that. I suspect there's a story like that, and I just don't know. In addition, as physicians, we like to be the ones in control and calling the shots. And when another physician comes in or someone comes in that wants to call the shots, that's both not the way the medical system usually works and we view it as a threat, especially if we're already struggling with maybe we feel incompetent or we feel insecure in some area. And then someone else is telling us how to do our job. We can respond pretty strongly to that. And I was doing that. I would do it differently now. Now, in my defense, I was scared and I was just trying to get the best thing to happen as quickly as possible. But I was not kind and empathetic. I just said what needed to happen. And so I would navigate that differently on my end. I think all of those elements come together. In addition, our medical system, I shouldn't have had to go to the ER for that. My institution should have allowed for me to get an MRI quickly, outpatient. That would have been the better option. But they were so backed up, it was over a month later to get an MRI. So the only option was for me to go through the ER to get my head scanned.
Because it's
And
then deemed emergent
yeah,
and
and we'll
it
do it.
gets covered.
Yes, you got it.
Yeah.
And then there are typical protocols. I mean, as you know far better than me, typically you get a CT scan in ER if you're concerned about intracranial pathology. In my case, I had enough data to suggest what it could be and where it could be, and that CT didn't actually make the most sense, and MRI made more sense. So it was a deviation from what's typical, which is also just hard to handle in the ER. And there was probably just some anger that I had come in. I had basically cut through the line. I'd called a friend of
Mhm,
mine who's an ER
mhm,
attendant, who called a resident and said, "Pull him in right now. Get him in a room. Get
mhm.
this to happen." And so by the time the attending find out what was going on, a lot of things had happened very quickly. And so there's a fairness component or feeling like I was misusing my professional courtesy. So there's probably that element too. And there are probably other things that I haven't thought of. But it's one of the things that's really opened my eyes is how difficult it is to navigate our medical system. I struggled immensely, and I have far more knowledge than the typical patient and far more privilege than the typical patient. And in spite of that, I got the wrong diagnosis initially. I had to really push to get the imaging done in a reasonable time frame. And I had to be the one to go out there and figure out what mutation this had and what options were out there. So my perspective now as a physician, when I intersect with these families, I'm far more aware and attuned to how difficult it is. Even something as simple as getting to the hospital, when appointments occur, when people are NPO, all of those kind of things that before I may have been just kind of brushed off. I'm just far more aware of each of the challenges involved with all of those steps.
I had a recent experience in the emergency department. I'm Jewish, but I had a recent experience when a child passed away. And it turns out that one of the grandparents was a preacher, was a minister. And they had asked me with the family in the private room after I had given some bad news to pray with them. And we went into a circle and there were things that were said. I was a listener and a participant in this circle where we held hands and we prayed. And It was one of the most beautiful experiences that I've had because personally, it's one of the most difficult things as an ER physician to do to essentially tell a stranger bad news that their child has passed away. And thankfully, it doesn't happen very often, but that experience and intersection of faith and medicine was very profound for me and continues to experience. And when we have really sick kids come in who are traumas or come in cardiac arrest, we have members of the clergy come down to support the families. And I find their presence to be very comforting, not only for us, and they're there to support everyone, by the way. And it's really beautiful. After you originally were diagnosed with a potentially lethal tumor, and bad news, how did faith intersect with you personally? Because I know that you've written about it. It's something that you talk about very openly on social media. And I would love to explore a little bit about how what role it's taken in the interplay of all of this.
Yeah. So it has played a huge role. I'm a Protestant Christian. Actually,
Hmm.
my dad's a pastor, and I
Mm,
grew up within the church, and it's been deeply interwoven in every aspect of my life. And it, while I've always been close to God and sensed His
mhm,
presence, His I was far more acutely aware of His closeness during my time of greatest need. And there's been a real struggle. It's not like I sensed just emotional calm through all of that. I was
mm,
really scared, really scared. I'm still scared because I don't know what may happen. Really sad. There's tremendous loss and grief in the midst of all of that. And it wasn't that God took all that away, but He entered in and He was with me in the midst of that. And I know Him, and in a far more intimate way than I did before. And there's one of the ways that I think we get things wrong or we get confused, especially in the church, is we are deeply uncomfortable with the negative emotions. And so I see this a lot. Maybe there's a child who's critically ill, or maybe has passed away, and people come to visit that family and they see tremendous sadness and grief. And it is so disorienting to step into that most of us don't know what to do. So we reach for these words that are often at least statements that don't help at all. It's, well, God's got a plan. God's going to take care of you. And at least you have other kids. And really what they're doing in that situation is managing their own emotions or trying to discharge their own discomfort. But
mhm,
what happens is the person who's really suffering just feels alone.
mhm,
And I had the full spectrum of people respond to me. Everyone is well intentioned. Some just didn't know how to handle it, and so made those kind of statements, or just wanted to bring my family dinner, which I'm grateful for, but they reached for something that they can do. And I had some people that were willing to sit with me and just weep. And that meant far more than any of those other statements that I may actually believe to be true, but ultimately didn't promote connection in the moment. And God, through friends and then directly, entered into those spaces and was with me, not with the promise of a good outcome. I mean, there's lots of ways this could have gone, and you and I see it go all different directions. I was not promised a good outcome. I was promised he'll never leave me nor forsake me. And so even holding to those promises in the midst of fear, the fear does abate somewhat, but then it comes and goes in waves. And it's not as simple as there are these various stages of grief that always occur in a nice sequential, logical way. They're waves.
Kubler-Ross has had yeah.
Yeah, they're
It's it
waves that hit you at different times when
Yeah.
you don't anticipate. And sometimes two strong emotions at once can emerge. It can be disorienting. And both my relationship with God, my perspective as a physician, and my willingness to enter into that space with my patients is profoundly different than it used to be. I pray for my patients regularly now. And so my now standard approach is every time I give a family a diagnosis, every time they go to a procedure, I offer to pray with them. And on the order of 98% of people in Arkansas want me to. And there's something about entering into that space. And I try to be very careful in how I pray. While I pray for a good outcome, I don't focus on that because I also recognize that if I just pray for good outcomes, that I can give them false hope, and I don't want to do that. So I acknowledge loss and grief in the midst of that. Sometimes I'll cry with them. I'll pray for God's presence to be with them, that they would experience his comfort and his peace in the midst of tremendous sadness. And I do pray for good outcomes too. But through that process, there's this deep connection that occurs with a family where they feel heard, they feel seen. And then the doors also open to conversations that wouldn't have been there before. If there needs to be a shift toward comfort care, as you and I often deal with, I found they're so much more receptive to that when you've engaged with them in that way
Mm.
to go into those places. And I've had a number of families that have then chosen to redirect care. And as their child passes away, we pray through that with them. And there's tremendous sadness and loss, but there's something so sacred about those moments.
Mm.
We know that the death and illness of a child is wrong. It is fundamentally wrong, and it rocks us to our core. And there's something about that, the way that impacts a family that is different than grandma or grandpa. And while there's sadness there, there's still a sense in which that's the way life is supposed to be. They've lived a good life. When it's a kid, it should not be that way. To walk through that with a family, while not enjoyable in a sense of it being happy or anything like that, it is deeply meaningful. And I'm grateful I get to do that. And I can step into those situations now in a way that I couldn't before. And I make that part of kind of my normal practice now. And it's opened a lot of doors that I don't think would have been opened before for me to connect with families. I think them feel heard and seen. And even in my own story, I'm real hesitant. People want to say, oh, God healed me. You're going to, God has a plan for you. He's going to do this or that. I don't know that. I know he's not going to leave me or forsake you. This may come back. This targeted therapy, I may not be able to tolerate it. There are a number of things that would cause me to have to go off. This is my only option. It's either this or I go back to a really high risk surgery or radiation that has all sorts of issues. This is not promised. I'm not promised a good outcome here. So I don't grab onto it like God has told me this is going to be.
Mm.
I don't know that. I know he won't leave me or forsake me. And I do believe in the resurrection. I believe that Christ will return and make all things new. I think about that. I long for that day. I think about that far more than I used to. I talk to my kids about it. We talk about heaven and what that'll be like. And even in an imaginative sense, like, are we going to be able to fly? What our body's going to look like? Like, not in this just vague sense in which we tend to talk about it. It's far more real for me than it was before. I long and hope for that day. That is promise. And I hold on to that.
It's interesting because Jesus was Jewish, and at that time, and still 2026 years later, roughly, I don't know if you're aware, but the idea of a Messiah actually started within the context of the Old Testament. You may know that. And actually, the Jews talk about a Messiah coming and changing the world. There are differences between Judaism and Christianity and the Muslim faith, but there are also many more similarities than people give credit to. And one of the similarities is that all three religions believe in God, that there's some higher being and some higher presence. And even people who are agnostic or even atheistic, many of them do believe in a higher presence. They may not say the words God, but in essence, it's what they believe in. I practiced for many years in Oregon, and then I also practiced in San Francisco and medical school, and then I was up in Connecticut, and I've spent a fair amount of time in the South, which has a high prevalence of folks of the Protestant faith, Christian faiths, and the various forms of that. And you had said 98% are willing. I'm curious because in Oregon or in other parts of the country where there's a higher percentage of more heterogeneity or a higher percentage of folks that are a-religious, I wonder if that approach would work or make people feel uncomfortable. But I think if you approach it in a way that's kind and not pressured, I don't know how anyone would feel really offended by it. And considering that all three religions do believe in some form of God, like for me, participating in that experience and fellowship with that family was profoundly, profoundly impactful for me as a physician. I want to talk. So you had said 98% yes. So there are a few percentage of times where you've approached families and they've said thank you, but not now, or like what's happened in the other times that it
I
hasn't
think
worked out.
I can remember two instances that I can
Hmm.
think. And I've done this countless times. One was someone that was, I think, just didn't believe in God. And I don't think I still care for her child. And I don't think she was offended at all. I asked permission if that's something she wanted. And the way I usually frame it, so I'll enter in and say, one of the things that I often offer to my families in these kind of situations is to pray with them. Certainly, there's no obligation at all, but is that something you're interested in? And they almost all say yes. The other, it was a situation of a parent that was under a high stress situation and was very mistrustful of everyone within the medical system at that moment. And so that probably contributed to her saying no in that moment. I don't know the rest of her story. And every other one from multiple walks of life, um, have have wanted me to pray with it. In the South, where a large percentage of people are at least culturally Christian, that can mean different things, obviously. That I know that influences things, whereas other parts of the country maybe less. There was a study, and this was a few years ago since I looked at this, that looked at a broader patient group. It was all adults, pediatrics, but it found that 90% patients want their doctors to offer to pray with them in the context of a new significant diagnosis or a procedure/surgery. And so it's interesting that we practice patient-centered care, yet that's not a regular practice that I've seen done. And I understand that, why a lot of doctors would be hesitant, especially if that's not a big part of their own life. But I do think our patients really respond well to that broadly.
Yeah, it's interesting because 100 years ago, we were going into the homes, and I'm sure there was a very much more intimate relationship between physicians and families and getting to know who they are in a very different way than we do now with the sterile environment of a hospital and or a clinic. What's curious is I think not our generation, but the generation older than us who were physicians were probably trained to have some distance between families. And I recently had an experience where I had a dad that came in with a child with a renal carcinoma and was having issues. And I had taken care of him a few years ago in the emergency department. And he said, "You've got a few boys too. I remember you telling me about your boys." And I don't recall telling him about my boys, but something about sharing my own personal experience with him, being a dad of boys, resonated with him. And we were able to bond over that. And I think improved our therapeutic relationship because the situation that I was dealing with that second time was not great. And having that kind of bond with a family, and you have the fortunate opportunity to have longevity with your families. You have a more longitudinal course where I'm very cross-sectional in the way that I care. So it's a little bit different. And, I find it really beautiful in your approach, especially in the context of all of your various positive and challenging experiences with being a patient. Well, I promise my audience these things are always less than an hour, and we're getting close to that. Is there anything that particular to this story that I haven't asked you that you'd like to share with the audience? And the answer could be no.
Yeah.
Or is there one or two teaching points? You're an educator listening to this, as let's say you are anyone, whether you're in healthcare or not in healthcare. What's something that you would want someone to take away from our conversation today?
I think there are a number of ways I could go, but the one that I want to emphasize is the importance of engaging and acknowledging emotions on the more negative end of the spectrum, ones that as humans we tend to avoid. As doctors in particular, we often don't go there, but are deeply important to what it is to be human. And I'm not someone that's overly emotional, and I am not someone that would have been deeply aware of feeling sadness and loss earlier on in my life. I'm now far more aware of that. But I fully believe that our willingness to sit in those emotions and not allow them to consume us, but to acknowledge them, to say them out loud, to feel, is directly related to our ability to experience the other end of the emotional spectrum. You can't selectively numb just one half. So if you're not willing to cry, if you're not willing to acknowledge loss and sadness and fear, like you're not going to experience the highest ends of joy and elation and deep connection um, that are offered to us. And I've learned a lot just going down this path in my own life about, well, I've done a lot of therapy. I see a therapist regularly. I would encourage others who, I think that's good for everybody.
So do I. I see someone every 2 weeks, whether I need it or not. And in the crazy world that we live in as healthcare providers, I find it essential that someone knows me that isn't my wife, that isn't my child, that isn't my best friend. It's someone who I can talk to.
And having to set aside time to engage in that space, to reflect,
Yeah.
to
Yeah.
think about our life, to what we're feeling, to give names to that. There's often beliefs underlying those. There's often, often I'm aware of feeling angry or frustrated, and those are often secondary emotions. So, for instance, I may have actually felt embarrassed, and then what I'm aware of is that now I'm angry at a situation or person. It comes
Mm,
out as anger, and
mm,
it's only in reflection and processing those that I'm aware that what I really felt was embarrassed. I hate feeling embarrassed, and so it manifests as anger in that moment. But developing those skills and those awareness and having that as a part of our life makes us more better humans just across the spectrum, but also much better doctors. And so I would encourage those that are listening today. I think there's great value in engaging in that space, being willing to go there. I wish it hadn't taken a brain tumor to get me there. I'd like to think that I would have gotten there on my own, but that's also part of how life works. Often the times of the greatest growth and maturation are through difficulties. That doesn't make what is evil good, doesn't make the brain tumor good. But I do believe that good has and will come out of it. I think I'm far more comfortable with my own emotions, more secure in who I am, and able to be an empathetic and kind doctor because of it. What happened was not good. Brain tumors are not good. But that nuance of recognizing that something can be bad, but it can be used for good, I think is an important principle for us to understand as physicians. And my hope is that others that may be going through something difficult would be willing to engage in that space as well and allow that part of them to develop.
Well, you've moved my heart. You're a beautiful human being. You're a beautiful physician. And the words of wisdom were very sage today, Josh. And I appreciate your time, which is one of our most important gifts is time, living, and giving some time to speak to me and the audience. I feel I know you in a very different way now through this conversation. And I look forward to further conversations with you and hopefully having you back on the show. So thank you for being here. Um, and my listeners, thank you as well.
Thank you, David. It's been a pleasure being here. I appreciate your willingness to let me tell my story. I think that is so important for human connection. And I wish that was more regularly woven into how we.
Well, that's the essence of HuMed or human medicine. We're really trying to unveil the humanity of medicine and all the work that we do. For those of you listening, please hit subscribe on YouTube. At the time of this taping, we're almost at 55,000 subscribers, which is just incredible. And we're also on Apple Podcasts, Spotify, and some other venues for podcasts. Please continue our journey, and thank you for joining today.
Thanks for listening to HuMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.